sometimes associated with eyelid swelling. And then what we call Gottran's papules, which are the inflammatory type rashes over the fingers and the knuckles. So she was getting all those manifestations as well as shortness of breath. A CAT scan was done and it showed interstitial lung disease or pulmonary fibrosis. And as part of her lab study, she had a strongly positive Jo1 antibody. So this all seemed to confirm antisynthetase syndrome. So when she came to see me, she was very short of breath. She was on oxygen. She was about 3 to 4 liters using the oxygen, more during activity, of course, than during rest. She had already tried a number of immunosuppressants that had been recommended by her local rheumatologist. She'd been on Cellcept, which is known as mycophenolate mofetil. She was on that for a couple of months, and it wasn't felt to be very effective for treating her disease. Therefore, she was switched to azathioprine, and then a couple months prior was actually given rituximab. So she had gotten all those treatments, and then she came to see me. On her exam, she had a lot of difficulty with getting out of the wheelchair to get up on the examination table. So she had a lot of what we call proximal muscle weakness in the hip muscles and in the thigh muscles. She also had what we call clubbing. So sometimes that can occur if you have lung disease and you're not getting enough oxygen to your tissues, and then your fingers will get this rounded appearance that looks like a club, and even your toes might in severe forms. And she did have that. She had the rashes. She had the heliotrope rash. She had the rash on her hands as well. And then when I listened to her lungs, they were quite coarse. So there was a lot of what we call crackles on her lung exam. And this is what her CT scan looked like. So what you're seeing here is a lot of what we call ground glass opacities. So that's the patchy whiteness that's seen on the periphery of the lungs. Sometimes it's only at the bottom of the lungs, but sometimes it's up higher, such as the middle and the upper lungs as well. She also had a little bit of volume loss, so low lung volumes, and something called traction bronchiectasis. That's when the lung tubes can become inflamed and then start to pull in some of the lung tissue. We call that traction bronchiectasis. So the question to me was, what else can be done for her? Recall she's been through already a lot of treatment and still not really getting better, in fact, actually progressing. So then we'll go into the classification of myositis. So historically, we've kind of grouped it into what we call idiopathic inflammatory myopathies. So this very much describes the muscle histopathology, so what the muscle looks like when you do the biopsy and you look and you see that the changes are consistent with either polymyositis or dermatomyositis or inclusion body myositis. And off to the side, encompassing both dermato and polymyositis, are groups called adult dermatomyositis, juvenile poly or dermatomyositis, as well as the malignancy-associated myositis syndromes, and then finally the overlap myositis syndromes, which overlap means patients who have a connective tissue disease such as scleroderma or lupus, and then they also have a myositis as part of that. So that was the original classification. You probably have seen this before. This is one of the older criteria, came out in the early 1970s. In fact, still used in a lot of the research studies today. It's a simple kind of criteria. It's a way of how we can classify people into either polymyositis or dermatomyositis. And you see that as part of the criteria, there should be evidence of muscle weakness, proximal muscle weakness, elevated muscle enzymes, which include the creatine kinase, the aldolase, even the LDH, AST, and ALT, as well as what we call myopathic changes on the EMG. So an EMG, I'm sure you probably know about the EMGs. They're one of the tools that we use to try to diagnose myositis, and they could also be used to diagnose neuropathies as well, but they're myopathic changes in myositis. And then if you get a biopsy, you hope you can see inflammation. And there are very characteristic locations as to where the inflammation is that help us classify people into poly or dermato. So not to go too much into this, it's really a way to distinguish polymyositis and dermatomyositis. Polymyositis, we like to think of muscle tissue as actually muscle fibers that are bound together in a muscle fascicle. So when you do a cross-section of it, in polymyositis, you see the inflammation throughout the muscle fibers, so right throughout the fascicles. But what's interesting in dermatomyositis, you see it around the muscle fascicle. It can also be around the vascular structures as well. So there's actually perivascular involvement with dermatomyositis. There's something called perifascicular atrophy. It's one of those findings that we see on muscle biopsies, usually in dermatomyositis and actually more common in juvenile dermatomyositis. What happens is that the vasculature is so involved by inflammation that it makes the muscle tissue kind of atrophy or loses the tissue there, and then we can see those characteristic changes on the muscle biopsy. So those are distinguishing features in the muscle biopsies between the two. So now a newer classification paradigm. Now we actually are moving away from just focusing on the muscle and actually focusing on the whole body, the systemic changes that can be seen with our myositis syndromes. So as time has gone on, we've been able to actually characterize syndromes better by the organs that they have affected, such as skin more, lungs more, joints more, and every syndrome seems to have their own characteristics that help us to classify them better. So now we have this umbrella term of autoimmune myositis. And underneath that is overlap myositis, dermatomyositis, necrotizing autoimmune myositis, which is also known as immune-mediated necrotizing myopathy. I won't spend time on that. Then polymyositis and sporadic inclusion body myositis. Underneath the overlap myositis, there are different sorts of syndromes, such as the CTD-associated myositis, which I think you heard about yesterday, was Dr. Yetterberg's talk. There's also a specific antibody called the MDA5-associated myositis, other myositis syndromes, and then finally the antisynthetase syndrome, which I'll go into now more. So we'll define the antisynthetase syndrome. So to have antisynthetase syndrome, you need to have an antisynthetase antibody. So that's got to be one of those requirements. And as far as I know, to date, there's 8 antisynthetase antibodies that I'll go into. And then, as part of having antisynthetase syndrome, you either need to have polymyositis or dermatomyositis. Polymyositis is more common in antisynthetase syndrome, but there are people who have dermatomyositis, including the patient I talked to you about earlier in the PowerPoint. And then interstitial lung disease is very prevalent. Over 2/3 of people who have antisynthetase syndrome have the interstitial lung disease. So those are the major features. And then there's some minor criteria. Some people have more of a complete spectrum than others, but other associated features include Raynaud's phenomenon. That's where the fingers turn white with cold exposure due to vasospasm. Mechanic's hands is an interesting skin phenomenon that can be seen with people who usually have that interstitial lung disease with the antisynthetase syndrome. Inflammatory arthritis. In people who have inflammatory arthritis, it looks like rheumatoid arthritis. And in fact, some people have been diagnosed first with rheumatoid arthritis and they end up having the antisynthetase syndrome. And then in about 1/3 of patients, there could be fever. Now, when I was a trainee, when I was learning more about this, I never really understood it. Like, fever, how can it be? How can you have a fever with this? Because a lot of times fevers can be seen with infections, right? People get fevers with infections. Well, sometimes you're looking for the infections, you don't find it, and then you got to say, well, it's because of the autoimmune disease. And I have a handful of patients who came to me having recurrent fevers, nobody could figure it out. It ends up they had the antisynthetase syndrome. Okay, so it was first described in 1990, And it was in a small cohort of 29 patients. And the patients had polymyositis or dermatomyositis and interstitial lung disease. And they identified antibodies such as the Jo-1 antibody in this subset of patients. And that's where the antisynthetase syndrome got coined. And then we, over the years, learned more and more about antisynthetase syndrome. The incidence is not very common, it's very low. So overall, in people who have inflammatory myopathy, so we call that idiopathic inflammatory myopathies, IIM, the incidence is about 6 to 10 million, so not common. And of those patients, it's only about 1.2 to 2.5, so a rare disease. Average age of diagnosis is 50, is what I say middle age, 50. The range, I have actually 20-year-olds, I know I put 22, but I actually have 20-year-olds who have antisynthetase syndrome, can all go all the way up to upper 70s and 80s as well. So there's a broad span patient ages represented. And the patients tend to be female, and I think that's true for almost all autoimmune diseases here. There's a strong female predominance. I don't think we quite understand why. In some series, more females than others, but generally we say in a 2-to-1 ratio. Here's an example of Raynaud's phenomenon. This is the classic white phase. Some people describe it as an attack. So something triggers it, such as you go out into the cold, and I'm from Minnesota, so maybe 20 below in the winter, and your fingers turn white. And it's due to those blood vessels constricting, and you've got lack of blood flow. It doesn't have to be the fingers, it can be in the toes, it can be in other areas of the body that's exposed to the cold. And then upon rewarming, it's painful, but upon rewarming, you get reperfusion, so you get the blood flowing back to into the digits. And then it turns red or violet or blue. So mechanics hands. Mechanics hands is interesting, and I've got a picture at the next slide to show you. What it is, it was first described in the late 1970s, is like a dry, scaly skin. And typically, it's along the index fingers and the lateral side of the index finger here. Although it can involve the thumb and the other fingers, I've also seen it on the palm. And it tends to be seen in the group of patients who have the lung disease, the interstitial lung disease. And my experience has been that I have seen people who, when their lung disease gets worse, their mechanics hands get worse. And also the flip side. I've also seen mechanics hands actually get better when the lung disease seems to stabilize. So I think it's interesting, and it tends to be a feature of the antisynthetase syndrome. Here are the mechanics hands. This is actually more of an extreme, severe form of mechanics hands there. So you're seeing here the dryness, the cracked skin, flaky skin there. Most of the time, that's right. Most of the time it's not that extreme. This is extreme.
Only extreme for those that didn't have
But it's also the waxy look, it looks like wax. I remember.
Yeah, it does.
It also hurts.
Yeah.
Does that hurt? Okay. Yeah.
It was more like razor cuts.
Is that right? Yeah. Yeah, a lot of people have told me that as well. It's just very painful in the digits.
It's like constant paper.
Oh.
Stop the eczema.
You think that that's the worst part, right? It's like ILD, whatever. No, mechanics hands off.
Right, it's your hand. Right. Oh. And then the inflammatory arthropathy. Not everyone has the inflammatory arthritis, but some people do. And it's where there's swelling, and it can involve the wrist bones, the knuckles that we call here, the MCPs, the PIPs. So it can cause stiffness and lack of hand functionality, worse in the morning. Those are the typical features seen in rheumatoid arthritis as well. And I have had some people who have come to see me, and they said, I was actually diagnosed with rheumatoid arthritis. In fact, they may have been put on treatment, rheumatoid arthritis, and then they end up getting myositis and the lung disease. And then it tends to be that they're evolving, or they get that diagnosis of antisynthetase syndrome. Sometimes the arthritis is deforming, so that means that the thumb joint sort of goes in like this, and then the outer one goes out, and we call it a Z-like deformity that can occur because there's malalignment of the joint itself, and that can come from a lot of inflammation there. If you do an x-ray, you might see calcifications where the bones are. You might also see something called erosions where you get holes in the bones, and that's the extreme form. It doesn't always happen that way. It could just end up being a little bit of swelling in the hand joints. What about the interstitial lung disease? So this is the most important contributor to the outcome of people who have antisynthetase syndrome. And I've reviewed a lot of studies. There are many studies out there trying to characterize interstitial lung disease in the antisynthetase syndrome. And why is it so important? Because over 75% of patients, or 2/3, will have interstitial lung disease. And it may start out insidiously. It may start out with a dry cough and a little bit of shortness of breath with some activity. It then can progress with more and more time and less activity and more shortness of breath. Then we have kind of tools to try to figure out, is this really interstitial lung disease? And one tool we use is called the pulmonary function test, where you got to blow really hard and we measure your lung volumes and how well your muscles around your respiratory cavity work too. So if your numbers are below a certain kind of level, then we say you have what we call restrictive physiology. So that means low lung volumes. The low lung volumes come because of inflammation in the lungs. That inflammation can lead to scarring, and then you have poor oxygen exchange there too as a result. Now, please tell me if I'm getting too technical in my terminology. You don't have to remember all these words, but it is important for the provider to know what type of interstitial lung disease you have. And why is that? Because you respond differently to treatment based on your subtype. So there's many kinds of ILD, but I only put the 3 common ones that can be seen with antisynthetase syndrome. One is called NSIP. We say that it means non-specific interstitial pneumonia. So what does that mean? That means when there's inflammation in the lungs, and when they do the x-rays or CAT scans, they see something called ground glass opacity. So that's like medical jargon, it just means inflammation. And characteristically, it's in certain locations of the lungs. NSIP is one of the more common kinds of subtypes in interstitial lung diseases with antisynthetase syndrome. In a way, it's kind of good because it does respond to immunosuppression. And then there's another subtype called COP, otherwise known as cryptogenic organizing pneumonia. The old term was actually BOOP. I don't know if anyone remembers that. BOOP, maybe you've been diagnosed with it. It stands for bronchiolitis obliterans and organizing pneumonia. Then they changed it and said it's now COP, but it's the same thing. Characteristically, when you get a CAT scan, it looks like little cotton balls all over the lungs. Kind of that's the appearance, that's the inflammation. Actually, this subtype responds very well to steroids if you got the COP. And then there's a subtype called UIP. That one, characteristically, when you get a CAT scan, looks like honeycombing. So it looks like just honeycombs throughout the lungs. And unfortunately, this subtype is not as responsive to steroids or other immunosuppression. So that's why we kind of want to know what subtype you are. I won't go into it too much, but just to know that it's out there. Here's an example of a chest x-ray of one of my patients. She has the NSIP form, but on the chest x-ray, you can see this is not normal. You see the whiteness, what we call opacities. Hers is mostly at the bottom of the lungs. And basically when you look at it, you say this is interstitial lung disease on a chest x-ray. Here's a CAT scan of another one of my patients, and it's a cross section. You're looking down through there. Here's the top and here's the back. Here's the right lung and the left lung. And you see the white haziness are what we call the ground glass opacities. Typically, it starts at the bottom of the lungs on the peripheries, on the outside of the lungs. And if it progresses, it goes more internally and then up the lungs. That's the usual progression. So, as stated, the prevalence is quite high. And some people who have certain antibodies, the prevalence can be up to 100% interstitial lung disease. There's different ways of how it presents in people. Sometimes it's right away. They get it. All of a sudden, they're good one day. The next day, they can't breathe very well. They're coughing and going to the emergency room. That's the acute form. Then there's a second type where it's sort of gradually, they just don't feel right. They've got lack of energy. They're coughing. They're losing their breath. That's kind of the chronic progressive form of it. And then you got another form where you just deteriorate. You just get really bad. Keep getting bad. I think of it kind of like a snowball going down the hill, gathering more and more snow. That becomes more what we call fulminant. And then you have a stage where there's no cough, there's no shortness of breath. We call it asymptomatic, but we do a CAT scan and we still see it. We see a little bit at the edges, and there's so minimal changes that it doesn't translate to any clinical significance in the patient. It's that group of patients that usually you might see that lung disease resolving. You hope that it does with treatment. And unfortunately, in a quarter of patients, it's usually the patients who are deteriorating and they got a chronic course that it can actually impede their functional activities. And so that can translate to a poor quality of life, unfortunately. Now here's a study. It's a very interesting study, and it's kind of characterized as the patients who have what we call the JO1 positive interstitial myositis with interstitial lung disease. So it was a French study. It was 4 centers, and actually there were 91 patients in this study. And of the 91, there were 66 who had the JO1 positive antisynthetase antibodies. So then they looked at those patients and they described what their clinical course was. And here's a large section, 59% actually improved, and that was reassuring to see. And 24% resolved too, so that all looks good. But what about the green, the 17%? What happened with them? They deteriorated and ended up not doing so well from their interstitial lung disease. So they identified certain predictive factors, and they found that this was an older group of patients. They were usually diagnosed at age 55 or more. The group also seemed to have the UIP subtype. So recall that's the subtype that's less likely responsive to steroids. So because they had that subtype, they didn't do so well. Interestingly, these 2 groups actually responded to steroids alone. This group needed more than steroids. Needed steroids plus very potent medications such as Cytoxan. So there were some clear differences. Questions so far? Yes.
Yeah, please. What was the criteria for the improvement? Just was it small, was it large? What was the criteria that put you into that category?
A good question. So the question was, what was the criteria to put them in the category of improvement? They looked at the pulmonary function test, and they basically use a percentage, such as if there's 10% improvement in what we call the vital capacity, or a 15% improvement of their diffusing capacity, and they characterized it that way. Yes, question?
So I've actually never heard of someone just going on prednisone and then improving and then that's all they ever take. So you just said, oh, they improved on prednisone alone? So that's...
The question...
Like you're saying they never were on Celsep, they were just on prednisone and that was it?
Well, the question is, did they improve on prednisone alone? The majority of the patients actually did, but within that group, they may have used more than prednisone. So there was more of a mix. Some only used prednisone, some used prednisone plus something else too.
Is it typical somewhere that you would only prescribe prednisone and leave that, like how long would they have been on I've just never heard of this.
Yeah.
Just putting someone on prednisone and then not prescribing something to take that.
Yeah, good point. So prednisone, it's unusual to see just prednisone alone, and in fact, it's not really my practice either. I usually don't
Okay.
use prednisone
Okay.
alone. This was
Just
too,
wanted to make sure
yep.
I'm giving you information.
And this was, I should say that the span of the study was from the 1990s
Okay.
throughout to the mid-2000s. So some of the more readily available treatment these days may not have been available back from the 90s too. Yeah. Question?
Just so I can get my head around it, if you are JO1 positive, doesn't necessarily mean you have antisynthetase syndrome. Is that correct? So my mother has JO1
Yeah.
positive. She's JO1 positive. Does that mean she has antisynthetase syndrome?
And so the question is, if you just have JO1 without the other features?
Oh no, I'm just trying to, because she doesn't really know. She gets confused and muddled when she goes to all her doctors and things. She's got DM and PM, and she was JO1 positive. So I'm just trying to work out, what does that JO1 positive actually mean when she has never told me anything about antisynthetase syndrome, if I'm saying that correctly.
Antisynthetase.
Yeah.
I can hardly say myself. So if she has the JO1 and she has, you said PM or DM?
She's got both. She's been diagnosed with DM and PM.
Well, she has an inflammatory myositis with the JO1. I would say that she does have an antisynthetase syndrome. Yes, question.
About 13 years ago, I didn't have the JO1, but I had the PL12.
Okay.
And they said I had the anti, so it's not just JO1, then it's other.
Yes,
Antibodies.
very good point. And I will get to that in later on in the PowerPoint, that there are other, besides the JO1, antisynthetase antibodies. Thank you for your question. Good question. Any more questions with this slide? Okay, so now the autoantibodies we'll talk about. This is somewhat basic information, and it's not specific for antisynthetase syndrome. Many autoimmune diseases have autoantibodies. And I know a few of the talks have already talked about what is an autoantibody. But before you can understand an autoantibody, you have to understand what an antibody is. And so the antibody comes from your immune cells, and you have all different kinds of immune cells. Two important immune cells are what we call T cells and B cells. That's one way we think of the immune system. We know the immune system is important for fighting off infections. The ways that they fight off infections is when the B cells are activated to make antibodies. And there's a particular cell called a plasma cell that makes these antibodies. Well, what makes the B cells make antibodies? Well, if the body recognizes that there's something foreign, right? So what can be foreign? A viral particle, bacterial particle, parasite. The body has these surveillance tools to recognize there's something foreign. They make a very specific antibody, which looks like a Y, 2 arms and then just a stem. And it makes the antibody go to that particular foreign molecule, bind it, and then activate other parts of the immune system to eradicate it. So the outcome is to get you free of infection, and that's what you always hope for. If you didn't have an immune system, you would be alive. But then something tricks your immune system. That's the problem. So what tricks it? We don't quite understand why your immune system gets tricked, but it does. And now the immune system doesn't recognize your own tissues and reads your tissues or certain parts of your tissues as foreign. And so when it starts doing that, I always say it's out of whack. So then it starts making antibodies against certain parts of your tissues, whether it be enzymes or something else. When it does that, then it's starting to attack your own tissues, and then it causes inflammation. So that's an antibody, autoantibody. Now, sometimes we know autoantibodies may be in your body, and they're just what we call innocent bystanders. They're just maybe swimming around, minding their own business, not doing anything. We call them markers. But then we also know of other antibodies that may be actually doing something to your body. maybe turning on some parts of your immune system or activating it when it shouldn't be. And we call those autoantibodies pathogenic. Does that make sense? Okay. The reason why I'm talking about it is because of the antisynthetase antibodies, but the question was the Jo1 and more, that there are other antibodies. So the antisynthetase antibodies. To understand antisynthetase antibodies, you need to know that your cells make protein. You have a cell with a cytoplasm and a nucleus, so just basic biology. In the cytoplasm is where all your proteins are made. Well, there's a scaffold in the cytoplasm that's called the tRNA, and it really does kind of look like a T. I wish I had a picture to show you, but it does, trust me. The enzymes in the cytoplasm take a building block called an amino acid, which is part of a protein, and stick it onto that tRNA. And that's what your cells do all day long. And then you start making longer and longer proteins. Well, for some reason your immune system that's tricked is now making autoantibodies against that enzyme that's supposed to take that amino acid and stick it on the tRNA. So that's what's happening. So you get these tRNA synthetase autoantibodies. And that's at the heart of antisynthetase syndrome. Does that make sense? Okay. Oh, another interesting thing is that if you have one antisynthetase antibody, you don't have another one. It's mutually exclusive. It's extremely rare to see someone to have more than one antisynthetase antibody. So that means if you have a Jo1, you're not going to have a PL7 or a PL12. You're just going to have a Jo1. Yet you may have an ANA. That's something separate. But just with the particular antisynthetase antibodies, you only have the one. So this gets to the autoantibodies. I know of 8. There may be more that have been discovered even today. I don't know. But I do only know of these 8. And the ones that I'll talk about are the Jo1, the PL7, and the PL12. These are less well known and less common. But I think in general, these are underrepresented because many of the tools, the kits that we had, only have become commercially available within the last 5 to 10 years. So many of these studies are probably underestimating the prevalence of all these other antibodies. And I'm sure if you come here in a couple of years, I'm still doing this talk, I might have this more updated. The Jo1 is the more common one, and the frequency is about 20 to 30% in people who have been diagnosed with just pure polymyositis, and then the frequency of 5 to 10% with pure dermatomyositis. Yet in people who have the antisynthetase syndrome, with all the characteristics we talked about, the representation of the Jo1 is about 70 to 75%. So Jo1 is very common, but it may be because we've just been picking it up since 1990 or 91 more than the other ones too. PL7 and PL12, I think of them kind of almost the same in a way in terms of characteristics, but there are some differences between the two. EJ, OJ, KS, HA, and ZO, they're exceedingly uncommon. I've probably seen only one patient, 1 or 2 with some of these, so uncommon. And so now the different phenotypes we'll talk about, which means the characteristics. Okay, so Jo1, the more common one. This antibody may be pathogenic. So there's actually mice models that they looked at mice and were able to figure out that this particular Jo1 antibody can actually turn on the immune system and activate it to cause inflammation. The patients who have the Jo1 may have more of the characteristics I talked about, such as the inflammatory arthritis, the mechanics hands, the Raynaud's, the fever. They may have more of the complete spectrum than someone else who has the PL7 or the PL12. Again, the interstitial lung disease is very common in Jo1, 70 to 90%. There are differences though. There was one study that was able to separate people who had Jo1 antibody with interstitial lung disease and people who had Jo1 antibody without interstitial lung disease. And one characteristic difference was that the group that had the lung disease had the mechanic's hands than the group that didn't have the lung disease. That's very interesting. I don't routinely follow the JO1 titer. I have, but I usually don't. But studies have shown that if you keep measuring it after treatment and it's going down, it's supposed to correlate with reduced disease activity.
Would that then correlate to lowering meds, or is you just assume that it's the meds doing a good job?
You kind of make that assumption that it, especially
The
with
meds
it.
doing the job.
Yeah. That's a good question though. I don't know if we even know, because I don't even have to study someone not on meds or something. That wouldn't be right to do it that way. Yeah. Yeah, but good question. Very good. Here's another thing about the JO1. Malignancy is rarely reported in this group of patients. And then even that led some experts to wonder, is the JO1 in some way protective of that? I don't know. There's always an exception. So I know of some exceptions of people who are JO1 and have a cancer. When we say that they get a cancer, it's usually within the first 1 to 3 years of diagnosis. So that's a cancer-associated myositis. But in general, you'll read in the literature that you don't usually see the cancer associated with the JO1 positive patients. Question?
You know, with the DM being less with the JO1, have you
That's a good point, yeah.
Have you spaced out to say, oh, those JO1s with PM versus the JO1s with DM? Like, does the DM over supersede?
Right. So the question is, are most of the patients PM rather than DM? And because of that, then there are less malignancy than seen, right? I think okay. That's a very good point. So people with dermatomyositis, there's a cancer is more prevalent. I want to say about 25%. I mean, within 1 to 3 years of diagnosis. You really don't see that with the polymyositis. You can, but not really as common. And with antisynthetase syndrome, you're more likely to see polymyositis than dermato, although I do see dermatomyositis. Question?
So even with the DM, it's still 3 years, and then what happens? If it didn't happen, then it most likely won't?
Well, then we're thinking it's probably not related. So people can still get cancers even with it 10 years down the line, but we just think that there's no association.
There's not a higher prevalence with DM patients versus the population.
After the 3 years. You know, and some studies even mark it out to 5 years too, so there is that range, but it's usually the 1 to 3 years where we think there may be an association with the dermatomyositis and the cancer at the same time. Yes, question?
No, that's fine.
Good questions, thank you. Okay, now the PL set. Oh, I'm sorry, question.
I had DM,
Yes.
JO1. I presented with mechanic's hands, fever, ground glassing. My question is, I was also diagnosed with a monoclonal gammopathy. Is that associated?
So the question is monoclonal gammopathy associated with the antisynthetase syndrome.
Right, and my DM.
Oh, the DM. I think taking the monoclonal gammopathy out of it and thinking of it isolated, I think it's actually a common thing, can be common to see whether or not you have DM or an antisynthetase syndrome if you're a certain age. I don't know of an association with the DM and antisynthetase syndrome though with the monoclonal gammopathy. Now the PL7 patients, they are not as common as the JO1. But like I said, there may be some underrepresentation, and maybe in a couple of years we'll understand really how many are out there. Interestingly, these patients may not have that much myositis, and if they do, it may not be as severe as the JO1. Now these are all generalizations. There's a study recently that looked at just this group of patients, PL7, and in the study they actually found some interesting differences, is that patients seem to have maybe more pericardial involvement, so fluid around the heart could be present in about 22%. And maybe it was just a coincidence they found it, or could there be a relationship to the PL7? Hard to know. but that was just an interesting feature that was seen. Esophageal involvement means trouble with the swallowing. So I have patients who have trouble with kind of pushing their food down because there's a weakness in the upper part of their esophagus called the cricopharyngeus muscle, or they may have a lot more of the reflux too. And then mechanics hands is common to see. In this group of patients, if they're more than likely to have ILD even compared to JO1, and when they do, it's more likely to be progressive form, where they could potentially deteriorate, unfortunately. The PL12 questions, yes?
I'm PL7.
Yes.
I, fit that to a T, for sure. But the other symptom I have is my nose peels. I don't know if anybody else in this room has that with ASS. By the way, antisynthetase is abbreviated ASS, and I love to tell people that I have ASS.
You know, I was going to say that I thought, no, I better not.
No, I'll say it for you. But I don't know if that is a symptom that anybody else has or if you have seen it, but I have lung disease, I have mechanics hands, and I have a peeling nose. So I don't know if you've seen that, but it's the weirdest, bizarre thing.
I have never seen that.
Okay. Just wondering. Yeah.
And just for you to know, if it's really bad antisynthetase, we can honestly say I have a cute ass.
Right? Thank you for bringing that up. So,
We can compare. I did have a lesion on my nose.
Oh.
I don't know if it's the same
no,
as the
not
peeling.
lesion. It just peels. It's like I have boogers hanging out
Oh.
of my head sometimes. When you say poor prognosis, because that is what I've read in my research, what do you mean by poor prognosis? Like, what does that's kind of general.
It is generalization. A lot of this is generalization too.
Yeah.
And it's really based on what's been reported too in the literature. Because it's such a more rare form of antisynthetase, I don't know if we can individualize it so much. So yes, in this cohort, but maybe this cohort was from France and it was in the 90s and there weren't a lot of medicines to treat.
Sure.
But it's really, I think, hard to pull it all down to you and on the individual level. But in terms of prognosis, which I'll go into a little later in the PowerPoint, an important contributor to prognosis is the interstitial lung disease and how is that behaving. Now, if it's stable or improved, your prognosis is going to be good. But if it continues to worsen, then that affects prognosis.
Okay, thank you.
The PL12 is similar to the PL7 in that there's a very high incidence of interstitial lung disease. And it's also similar in that there's a lower incidence of having the myositis. So if they do have the myositis, it may not be as severe as the JO1 patients. Unfortunately, in this group of patients, the UIP subtype is common to see based on the literature. And as we talked about, the UIP is the subtype that's not as responsive to steroids and immune suppression. So I think that's why there may be a poor prognosis with the PL12 antisynthetase syndrome. Unfortunately, when you have the ILD in this group, you could progress and deteriorate. Now I'll spend some time on treatment, and when I'm talking about treatment, I'm talking from my perspective. So you may have rheumatologists who do it differently. This is just the way that I do it. So this is a little bit of a busy slide, but it illustrates my thought processes of when I'm seeing a new patient who's referred to see me for an inflammatory myositis. The very first question that's on the top of my head is, does the patient have interstitial lung disease? Because it really does inform your decision making in terms of what to choose for treatment. So say the patient says, yes, I'm coughing, I'm short of breath, and you're really highly suspicious, and then you get a chest x-ray and there you go, you see some fibrosis. So there's interstitial lung disease. So if there is interstitial lung disease present, what's the severity of it? So in order to determine that, there are certain tools that you could use. One tool I use a lot are the breathing tests, the pulmonary function tests. they're highly accurate in telling me the lung volumes and how much the respiratory muscles are affected as well by the myositis. So I use the pulmonary function test. I also use a high resolution CT scan. It's more accurate than a chest x-ray. It's costly, of course, but it is more accurate. And it helps to clarify the extent of the interstitial lung disease. So if it's just in the bases, on the periphery, that's not too bad. To me, that's mild. If it's involving all the lung zones, that's severe. Another good thing about the CT scans is that the characteristics seen on the CT scan are so specific to the subtypes that you don't necessarily need to get a lung biopsy. And so pulmonologists have kind of gone away from doing all these invasive lung biopsies. If you got a Joe 1, for instance, and you got a CT scan that's showing an SIP, then we know, there you go, there's the diagnosis. No further testing then will be needed. So that's what I do when I assess for severity. Mild and moderate, I'll talk about a little later in the slide set here. I'm going to pick therapies that I think are going to be unlikely to worsen the lung disease. If it's severe ILD, I know that time is of the essence here, and I need to start on high-dose immunosuppressive agents that are potent to try to get the inflammation turned around, which I'll talk about. And I also want to make sure there's no underlying pulmonary hypertension, because people who have moderate to severe ILD are at risk for getting what we call secondary pulmonary hypertension, where you get pressures that are really high in your heart, and then your heart starts to maybe fail, and you can get short of breath, so you need to be on therapies to prevent that from happening. So that's one arm. What if they don't have ILD? Well, then life is relatively easier, because then I don't have to worry about complications from ILD, and then I assess for myositis severity. And when I assess for that, in another slide I'll talk about how I do that. Basically, I'm testing muscle strength, I'm testing muscle enzymes, I may be doing an EMG or an MRI, trying to classify whether the myositis is mild to moderate or severe. If it's mild to moderate, I just proceed with standard therapies for just treating the myositis. If it's severe, I kind of use the same sort of protocol I use for severe ILD, with the exception of I don't check the pulmonary hypertension. There wouldn't be a risk for that. Does that make sense? Okay.
On the PFTs, are you looking for just anything below normal, or are you looking for way below normal to put it in the severe category?
For the severe category on the PFTs, a lot of times the pulmonologist reads it and tells me, classifies for me the severity of it, and they use certain numbers. But even if they're not where they need to be, normal, I want to know, because you're using that as a baseline for comparison. And if they do have way low numbers, say the diffusing capacity DLCO is less than 50%, for instance, sometimes that is a poor prognosis, that you're starting at baseline with really low numbers, which means that the lung volumes are small.
I'm just trying to figure out if you're at 70 or, anything
Yeah.
below, like where is the mild to moderate, like you have your symptoms, but you see it in the CT, or is there just in your practice, how you jump from the mild, moderate to the severe? But I guess you just rely on the pulmonologist.
Yeah, a lot of times I do that. Sometimes they'll do there's other things like testing for oxygenation too, at rest and during activity. Yeah, like if there's a cutoff for like less than 88% or something during activity. And that could be them, if I know that their oxygenation at room air is low, not normal, that puts them in a different category and they may require oxygen too. So that puts them more into the moderate to severe category. Yeah. There was a question, yes.
So if they do not have ILD, how often do you go back to check? How often?
That's a very good question. So if there's no ILD detected at baseline, but there is an antisynthetase antibody and you know that there's a high risk for getting ILD, I'll end up still checking for it. I may wait 6 months or a year and just check breathing tests and compare to the baseline to see if there's any difference in ILD. But that's a good question, because what do you do if someone doesn't have any of the symptoms, and you're not suspicious for ILD, but you see the JO1? How much do you go looking for the ILD? And I think it really depends on, I guess, your nervous level. I'm a nervous person, so I will end up kind of checking everything to make sure I'm not missing anything. But sometimes it's not done. Sometimes maybe it's just a chest x-ray. Then it's until the patient starts saying, I'm really not feeling good, I'm coughing, I'm fatigued, and then you go looking for it. Okay, so here's my approach. This is what I say is first line for me. So I always start with steroids, and I pair it with what I call a steroid-sparing agent. The rationale is that the steroid-sparing agent is going to limit your exposure to steroids, at least moderate to high doses of steroids, so you're not affected by side effects, hopefully not. But I know that the steroid-sparing agent is going to take a while to work. Sometimes you have to start really low and then slowly titrate to a dose that's going to be tolerable and effective. But that takes time, and it takes about 6 to 8 weeks to get that, or longer, to get a steroid-sparing agent to work. So that's my rationale, and this is my approach. Some people do a different approach, but this is how I do it. I'll either start azathioprine, also known as Imuran, or mycophenolate mofetil. Sometimes it's a difference in, now this is getting a little technical, stop me if I'm saying too much medical jargon. But sometimes what I do to determine which one I'm going to choose, I'll check something called a TPMT level. And if that level is too low, I don't use azathioprine, because I know it's not going to tolerate it well, so I'll go on to mycophenolate mofetil. Those are the two I tend to use if there's interstitial lung disease present, and it's mild. If there's no interstitial lung disease, I'll use a methotrexate. So see how that kind of informs my decision for treatment, if there's ILD underneath. In terms of the steroid dosing, it really depends on the severity of the myositis or the interstitial lung disease. If it's severe enough they can't get out of bed, if they can't swallow, I'm going to give them IV steroids. And I'll do it for 3 days in a row, sometimes a little longer in the hospital. And then when they get the steroids IV, then I convert them to oral high-dose steroids based on their body weight. And I usually use, just not to be too technical, but a milligram per kilogram, use it for 4 weeks, and then I'll start to taper over time. So that's my approach for using the steroids. Sometimes I'll taper until I get to 5 to 10 milligrams, and if there's underlying interstitial lung disease, it's sometimes very difficult to get lower than a certain dose, and it's usually around the 10 milligram dose. And I've had patients with that for a long time. There's a thought that in some people who have inflammation in their small airways, if you get down below a certain number, then that starts to flare. So that's why they need some low level of steroids to keep that inflammation at bay. IVIG, I sat in on a talk yesterday with Dr. Yedmer, a lot of questions about IVIG. We don't really know why it works really well, but it does. And there's different ways of using IVIG. I've used it many different kinds of ways. But usually, if the person is having severe manifestations, I'll use the IVIG up front, because I know it's going to work faster than a steroid-sparing agent. I'll pair it with the steroids and steroid-sparing agent, and then I'll dose them usually for up to 3 months initially, just to see if it's going to work. And if it doesn't work, then we just stop it. Or if their myositis is stabilizing or getting better, then we can stop it if we don't need it anymore. If they respond at 3 months, but they're still not where they need to be for improvement, then I may extend it longer, 6 months, 9 months, 12 months, even longer than that, to see, to use it as kind of a therapy for the weakness and their overall myositis. This is my recipe, but not everyone uses this recipe. Some people use a lower volume. Some side effects with the IVIG can be headaches. It's kind of more of a common side effect, either during or right away after the infusion, or nausea can be part of it. Some people can have trouble with neurologic symptoms. A serious side effect is actually aseptic meningitis, and when that happens, it just stops it. There's also a rare risk of causing kidney failure and a rare risk of causing blood clots because you're getting a volume of a drug that could increase the viscosity of your blood and increase risk of blood clots then. Okay, what if there's severe disease? That's when you pull out the big gun. That's why you pull out cyclophosphamide then. There's studies have shown in people with antisynthetase syndrome that it can be helpful, There's two ways of getting it, IV or oral. IV, you get less of the side effects involving the bladder. The cytoxin has a lot of potency to it. And when you use it with a cutoff of how you're not going to use it for a long time. So some people use it up to 6 months, for instance. And then if you go beyond that, some people use it up to 12 months, but if you go beyond that, there's just a higher risk of infections and the white count going down too low. There's also an association with causing bleeding in the bladder, which we call hemorrhagic cystitis. So we will always monitor for that. What about cyclosporin or tacrolimus? Those are medicines I've used as well. I've actually used more tacrolimus than cyclosporin. That could be used if everything else maybe has been used and you're still not getting better. And so that's a drug that you could add to the existing therapy. And then you got to make sure there are no side effects, including high blood pressure, electrolyte derangements like low magnesium can happen, tremor, peeling rashes. Questions with all of this? Yes.
I was prescribed methotrexate right
Yes.
away, even though I have ILD. And in addition to Celsep and high-dose corticosteroids.
Yes.
And I asked my doctor, my rheumatologist, why they would give me methotrexate, because I had studied up and knew that it could be detrimental to my lungs. And his answer was, it was a good answer. He said, well, we think in your case that the methotrexate will be more helpful.
I should say methotrexate, it's not as common to cause a lung problem. So methotrexate may cause something called an interstitial pneumonitis, which usually occurs within the first few months of starting it. The trouble is that if you get it and you already have lung disease, you don't know if it's from the methotrexate or an underlying disease itself that's flaring or getting more active. And so that's why it's my preference not to use it. But I also know of rheumatologists who do use it, even with underlying interstitial lung disease, because that risk they think is not that high. The other thing too is that methotrexate really helps the joints.
Yeah. And I was having a lot of that.
Yeah, so methotrexate helps very well for inflammatory arthritis and joint pain. Mycophenolate does not. So that might have been the rationale in your rheumatologist thinking. Other questions?
The tacrolimus, could you comment on your rationale for twice daily versus once daily? More experience with tacrolimus twice daily?
Yeah, I usually start at a very low dose and start at the twice daily. Maybe the once daily is a much lower dose. If you're a low body size or if you have underlying kidney disease, maybe the rationale is just to dose at a very low dose then at once daily. What about rituximab and myositis? Rituximab is very familiar to most people now. We know it's a B-cell depleter. It's a chimeric antibody that binds to CD20. So it wipes away those B cells that I talked about in a couple slides back. Remember, the B cells are important for making the antibodies. Well, we know the antibodies are there in antisynthetase syndrome. So rituximab shuts off the antibody production. And there was a large trial that was published, when was it, 2013, yeah, of about 200 myositis patients. Now, it wasn't all antisynthetase. It was juvenile dermatomyositis, adult dermato, and polymyositis patients, and it was placebo-controlled. But they found that there was actually 83% who met the definition of improvement. So even though maybe the endpoints weren't necessarily met, they did improve. So we extrapolated from the study to say, well, rituximab may be really helpful in treating myositis and people have antisynthetase syndrome. And since then, there's been case series that have reported improvement as well in myositis patients. I do use it. There's 2 ways of using it. You can use it for 2 doses or 4 doses. The 4-dose method is 1 dose every week for 4, and then repeat in 6 months. The 2-dose method is getting a little higher dose, separated 2 weeks apart, which is easier to do. And then you may repeat in 6 months. Sometimes I've seen it work. I've seen a handful where it doesn't work in my patients, but sometimes it does work. Things to remember about it is that it does shut off your B cell production, and it's off for 6 months or longer in some people, and so you're at higher risk for getting infections, so you have to worry about that. Since the study, they've actually found that there may be a subset of patients who respond better to rituximab if they have really super high autoantibody levels, and they've been able to correlate when the antibody levels, I think that was your question, when the antibody levels decrease, suggests a clinical improvement. They also may improve faster with rituximab, was one of the outcomes. Yeah. Okay, so this is my approach again, okay? But these are usually the medicines I don't use in people who have the interstitial lung disease, complicating their myositis. The inflammatory, I don't think there's a lot of data. That's also known as Areva. It's a medicine that's used a lot for rheumatoid arthritis. I don't use that. I know there are case reports of using something called plasmapheresis in JO1, but I have never used it. I've never used these other medications. Abatacept is used in RA. Belimumab is used in lupus. I haven't used those. And then any of the TNF inhibitors, like adalimumab or Humira or Enbrel, there's a thought it could worsen lung disease, so I just don't use it. I don't know the data, too, behind that, using it. What about if you have reflux? So this is more expert opinion in the pulmonology literature. But there's a thinking that if the reflux is poorly controlled or inadequately controlled, potentially it may exacerbate underlying lung disease. So we try to do our best to control the reflux by various methods, either conservative-wise, lifestyle changes, elevating the head of the bed and avoiding certain foods late at night, or smoking and alcohol, or being put on a PPI, proton pump inhibitor, an H2 blocker. Also, if there's trouble with swallowing, so if you got weak throat muscles, you're more likely to aspirate back into your lungs your stomach contents, which can cause a flare of your underlying lung disease. So you just want to make sure you're trying to control for that. This is more maintenance, but you want to always remember to check for infections. I always screen people for latent TB, especially if people are going to be put on high doses of steroids. There's a risk if there's ever been hepatitis B exposure that virus can reactivate, because you're being put on medicines to really suppress your immune system. I always check their vaccination status, and then many of our medicines can cause diabetes, high blood pressure, and osteoporosis. So make sure that you're treating that or not giving them super high doses of steroids and making the diabetes go out of control. Some of my patients are in their 20s and 30s and early 40s, and they're still of childbearing potential. It becomes a very sensitive discussion then about what to do. These medicines, many of them are teratogens, so they can cause birth defects. If they're given Cytoxan, they need to harvest their eggs if they want to have a family later, so that becomes important to discuss. And then if you have lung disease, you're at higher risk for getting pneumonias, right? And then if you're given steroids, you're even at higher risk. So a lot of experts say you got to be put on some antibiotics to protect you from that risk. Commonly, it's Bactrim if you don't have a sulfa allergy. And then if there is infections, I see commonly shingles, for instance, with certain medicines. You got to sometimes stop the medicines or reduce the dose. And now, assessment of treatment response. So, as alluded to before, what I do to try to figure out if people are getting better or responding is I measure their muscle enzymes, I measure their strength. If the lungs are involved, I do the PFTs or the breathing test. I may check other tests such as EMGs or muscle MRIs to see if there's improvement.
On the improvement or stabilization of muscle strength, I've been less than impressed with my rheumatologist checking for strength, because you say, well, push here. You know, if I'm able to do this, then I must be just fine, with no regard for what I did a year ago. What is your approach to actually testing of muscle strength? And to be able to have an objective measure, so we're not waiting until I can't do this in order to.
Yeah. Yeah, that's a good question. So the question is, how objective can you really be by the clinical exam and assessing for muscle strength? I think it's very difficult to do, especially if someone comes in of a larger body size and it's hard to overpower and it's hard for me to detect any subtle weakness. Sometimes I have to really rely on what the patient tells me. So if they're telling me, yeah, I used to be able to throw hay bales into the truck and I just now can't really do it, I mean, that's important to them, but if I can't really overpower them, I don't necessarily use that then as a criterion that they're getting better. I listen to what they tell me. Sometimes you can be more objective and you can do an EMG, for instance, and compare to the one the year before to see if there's any difference. It's more costly, but you can get a muscle MRI to see if there's muscle inflammation. In the center that I work at, I actually work with physical therapists who can actually do the muscle strength measurement for me and can compare. I can get a baseline, they can compare to see if there's any differences. Yes?
I was just going to say that in my clinic in Stockholm, Sweden, that's what they do with the physiotherapists.
Yeah,
And they have a
very
scale, they
helpful,
measure
yes.
me every year.
Yes, it's very helpful, and that scale has the norms for your age.
And then
Yeah.
she gives it to my rheumatologist.
Yeah, so that is more of an kind of an objective evidence, but it just boils down to what the patient tells you too. You just gotta rely on that. And unfortunately, muscle enzymes may not be accurate either, you know? Right. So the CK may normalize, but you're still getting weak. So the CT is not necessarily a reflection of disease activity. It makes it tricky, I think. Question?
What does LDH stand for?
Good question. So that means lactate dehydrogenase. It's a muscle enzyme. It's not commonly elevated in people with myositis, but can be. And so some muscle experts will routinely measure the LDH in addition to the C, PK, aldolase, AST, and ALT. And now the last part of my discussion will be about prognosis. How am I doing on time? Am I over?
We don't care.
Am I, okay, I'm sorry if I'm over. Okay. The interstitial lung disease is the most important contributor to outcome and survival. Morbidity means kind of quality of life. Mortality is your survival. That's the number one thing in antisynthetase syndrome. So we talked about how to measure severity of the interstitial lung disease. If someone comes in and their markers are really low on their breathing test, like the DLCO or the FPC, which is the forced vital capacity, which is a marker of your lung volumes, that's not necessarily a good sign then. Then that means we're starting at a level where we gotta do our best to try to get that back up, to get it back up to normal. But it could mean that there'd be a lack of treatment response. So that is one of the takeaway points, I think, in this talk here. Alluding back to our subtypes, the UIP, unfortunately, is the one that does not respond as well to treatment. And if you got that as a subtype, unfortunately, you may be in that group of people that maybe don't do as well as hoped. If you got respiratory muscle involvement, so in your rib cage here are the muscles involved for breathing, and if those muscles are weak, actually you can deteriorate really quickly from that, and that can be a function of the myositis being very severe.
Is there a test to be able to test those?
Yeah,
muscles?
it's the breathing when we call it inspiratory and expiratory pressures. It's also known as bugle
So
pressures.
it's part of the PFT?
Yeah.
Oh, okay.
Yeah, it's part of the PFTs. Mm-hmm. Yeah. And as stated before, if you got the progressive ILD, it can occur in about a quarter of patients, unfortunately. So these are additional complications that can occur. Most of them are a function of having ILD or poor swallowing mechanism. So infectious pneumonias may occur, aspiration pneumonias. The secondary pulmonary arterial hypertension I talked about, where the heart pressures get really high because the lung pressures are really high. And if the heart pressures are too high for too long, the heart starts to remodel, where it gets bigger than it should, and then it doesn't pump the blood out like it should, and then you can go into heart failure. And then the ventilatory failure just means you just don't breathe as well as you should, and you need more oxygen requirements. Question?
Is there a time factor associated with, have you done any statistics?
About the complications? Yeah,
When do you get pulmonary hypertension after?
no, that's a really good question. A lot of times it's a factor of the severity of the ILD. So how bad does the ILD need to get? In some people it's rapid, and others it's more of a chronic course. Where I've seen patients for 5, maybe 10 years, and then all of a sudden they get the pulmonary hypertension because the ILD gets progressively worse and worse. So there's different patterns to it. I think it really relates to how fast the ILD progresses, if it does. Now, way back in earlier in the 90s and even in the 80s, there were studies looking at people who had inflammatory myositis, who had ILD, and compared them to a group of patients who had what they called idiopathic pulmonary fibrosis. That, I don't know if you've heard of that term before. Those are patients who have lung fibrosis but no autoimmune disease. So they compared and actually found the survival rates to be the same. Recently, however, we found survival rates are better in people who have an autoimmune associated lung disease compared to pulmonary fibrosis. So that's kind of a little bit silver lining in the cloud there. So one study looked at them with follow-up of 53 months, looking up 1 year, 3 years, and 5 years. So survival of 86.5% here is much better than the 60% that was historically reported. And some studies even more than that. So there is a silver lining. Relapses are common. And then back to the question about the steroids alone, more common in people who are only treated with steroids for their lung disease. So they maybe have less survival advantage. Question?
Okay, this is a really important topic, I think. So initially, we get a virus. Our immune system overattacks, has a party, destroys our lungs. But what causes a relapse? Do we have to get another virus? What exactly is it that causes a relapse? Because from my understanding, it was an initial virus. So do we have to get another virus?
I don't know
Please
if we know
explain.
it's a virus. I don't think we've really identified the triggers first for the disease.
Okay.
And they're doing studies, believe me, at the NIH, and they're looking at all the triggers, environmental, etc., that could start it. Relapses can occur for a number of reasons, such as if you get a pneumonia or the flu, well, you don't have a lot of reserve in your lungs if you have the lung disease, and then you relapse and get worse. So I've had some patients cruising along, they're doing great, then they get the flu, boom, and then they relapse, and then they seem to hardly ever recover, unfortunately.
But when you're put on Cellcept,
Yeah.
which is an immunosuppressant,
Yeah.
and you're more susceptible
Yeah.
to the flu and the
Yeah.
pneumonia, it's like a double-edged sword.
I
It's
know.
like, should I take this
I know.
and risk myself?
Right? I know. It makes it life very hard.
Okay.
I understand.
That is my burning question.
Yeah.
Yeah, because
It's a dance of trying to make sure you don't
Right.
get the
It's a dance.
infectious complications,
Yeah.
but controlling your disease at the same time.
exactly.
Yeah. And then we always say make sure you're getting your vaccines, you know, in order to try to protect you.
Thank you.
Question?
Yeah, I have a quick question. Just going back to what you were talking about that happens in the cell. I mean, Ian, correct me if I'm wrong, but it seems like the implications here with the antisynthetase syndrome would involve a reclassification of lots of people with DM into this larger syndrome based on the cell level activity. Right, people with multiple symptoms. Instead of, because we know the diagnosis of DM usually from the deep muscle biopsy, right, what's happening in the muscle cell. But what you were talking about is like transfer RNA, and so are you saying that this is, especially people who have ILD in CAN's hands, I mean, is that an patient?
Of the antisynthetase syndrome?
That instead of DM, they actually have antisynthetase?
Well, the
Or
The
they have
DM
DM
is
and-
part of, can be part of it. But you can only have DM alone
Right, right.
without all the other symptoms. Some people have just DM with skin, and that's it. But the antisynthetase, you have DM or PM plus the other, what we call extraskeletal manifestations, so outside of the muscles, like the lungs, for instance, or the joints. Does that make sense?
Yeah.
Okay. Question?
About with Bactrim, if you're allergic to Bactrim or you don't do well with it, what could you take?
Yeah, that's a good question. There are other alternatives. One is called atopicone. It's expensive. It's a liquid. I think it's ATOVAQUONE. I may be wrong on that. The brand name is Malone. It's expensive. It is a prescription. There's also Dapsone, but that has a sulfa moiety, sulfa part. So some people switch to Dapsone, still get allergic to that too. Then there's also inhaled pentamidine, where it's once a month you inhale something called pentamidine. It's not as effective because there's a thought it could only reach the upper lung zones more than the lower. But some pulmonologists use that as an alternative if you have a sulfa allergy.
So is taking Bactrim, like, you should do that, or whatever medicine you take. Is that for like moderate or mild ILD, or, is there certain?
Yeah, that's a good point. If there's no ILD, you probably don't need it unless you're on really high doses of steroids or very potent medicine like Cytoxin that you do. But if you have asymptomatic or very mild ILD, it's not as then imperative to be on it. But if you have moderate to high or severe ILD, yes, you should. Question.
So they didn't start me on Bactrim until they started me on Celsip. Is there a correlation there?
Were you also on steroids too? Or?
I'm still on
Still on the steroids
low
too.
dose now,
Low dose.
but I was on pretty high dose then.
Yeah, so sometimes I'll go on the dose of the steroids. Like for instance, 20 milligrams or higher for longer than 4 weeks, 2 to 4 weeks, they'll put you on Bactrim. Yeah.
40 milligrams.
Yeah, that's probably why. Another question, Ms. Becker?
I went to another meeting and they said something about DMs, and also you mentioned that DMs are more prone to getting cancer.
Yeah.
I think one of the tests that she mentioned would be NXP or something. That would be what other things that they're supposed to be checking for?
So checking
NXP.
certain autoantibodies. So NXP2 is an autoantibody. It doesn't characterize antisynthetase syndrome though, but it has been associated with cancers. There's another one called TIF1 gamma. It's not an antisynthetase antibody though, but there are certain autoantibodies that are more common than you can see cancer, but not always. Question.
I'm not sure this has been asked before, but is Bactrim something that you would recommend taking with ILD for a longer period of time, even when tapering medication? Or would you stop it after, let's say, because some people do taper?
Yeah.
What are your thoughts about that?
So the question is, should Bactrim be used for the long term when there's underlying ILD? That is a very good question, and it's mostly answered by expert opinion. I work with pulmonologists closely who have help me take care of ILD patients, and I have seen that it's in their practice to continue the Bactrim for the long term, unless there's a side effect or intolerance to it. Now, some people use the criteria of a dose of the prednisone. So if they're below a certain prednisone dose, such as 15 to 20, then there's a thought you don't need the Bactrim as much. But then the pulmonologist standpoint is, well, you already have damaged lungs, you have higher risk for getting pneumonia, so then the Bactrim will be protective for that. But this is expert. This is delving into the nitty-gritty details. Yeah.
So we should ask our pulmonologist.
Yeah. What it boils down to, yeah, good. Yeah. Okay. So I think we're kind of running out of time. Well, does anyone have time?
4:49.
What is it? Is it really? Okay. I won't belabor this slide too much. This was a study that had come out even just this year. And it's not all inclusive of antisynthetase patients, but the point of it is that patients who have an autoimmune associated ILD, like UIP, when compared to patients who have idiopathic pulmonary fibrosis, the autoimmune patients do better. So that's kind of a good thing to see. Another study came out a couple years ago, and this was actually comparing people with Jo-1 antibodies with people who have other antisynthetase antibodies, such as PL7, PL12. And they came out saying that there was a little higher survival in the Jo-1 compared to the other antisynthetase antibodies. But the authors of the study said, well, it may be because there was a delay in diagnosis, because there weren't many, the kits that were available during certain time frames weren't picking up the other antisynthetase antibodies. So when there's a delay in diagnosis, there may be a delay in treatment. So now I want to just touch back on my patient. So I saw her recently. She came back. I hadn't seen her in over a year. And she was actually started on tacrolimus in addition to the azathioprine, in addition to the steroids. And she has done better in some respects. She was better with her rashes. They went away. She was able to get down to 5 milligrams of prednisone. Recall she was on 25 and 30 and couldn't get down very low beyond that. Yet, even so, she was still feeling fatigued. And now she was telling me she was feeling a lot of difficulty with walking. So that aspect of things was worse. And this was her chest x-ray. So it shows a lot of fibrosis there. And not only the lower lungs, but also the upper lungs too. And this may not project very well, especially in the back, but this was an example of her pulmonary function test. And when I saw her last year, like one value here, the forced vital capacity, was operating around 45% of predicted, but then now 27.9. So she has gone down in her forced vital capacity. So that indicates her lung volumes have shrunk, and that's why she's feeling more short of breath. She ended up going to a cardiologist, and she got a right heart catheterization, which actually did show the pulmonary hypertension, which can come as part of the interstitial lung disease. She saw the cardiologist who recommended medications, which I'll go into, for her pulmonary hypertension. Yet he thought maybe the outcome wouldn't be as what we would hope for. So therefore, we're talking about using cyclophosphamide with her and potentially having her see a pulmonologist for a lung transplant. So that's just one kind of illustration of kind of the course of some patients who have the antisynthetase syndrome. And not to be very depressed about this, because I also have success stories too. But she was on my mind. I've seen her recently. So in summary, the definition of antisynthetase syndrome, remember it's DM or PM with other extraskeletal manifestations such as inflammatory arthritis, Raynaud's, mechanics hands, fever. There seems to be differences according to what antisynthetase antibody you have in your manifestations. With the Jo-1 positive patients having more of the complete spectrum of antisynthetase syndrome than the ones with the PL7 and the PL12, for instance. Remember the interstitial lung disease, it's important to control it right away. My treatment approach is to use the steroids plus immunosuppressives and then try to taper the steroids as low as possible. And then the prognosis does differ in terms of what autoantibody you have and compared to people who have interstitial pulmonary fibrosis or idiopathic pulmonary fibrosis. There's a better prognosis if you have autoimmune connective tissue disease lungs. So thank you guys for your attention. Any more questions?
Have you had anyone with a dry heat and the symptoms and so forth?
Like nausea?
Well, not productive, just dry heat. It's lasted for about a year and a half.
Not common.
And nobody, I tell them now, they're going to shake their head.
Yeah.
It's not a symptom to anything.
Unless it's a side effect of the medicine. I've seen
I've
that.
been off, it happened after I was off the medication.
Okay. Interesting. Hard to know. I must be frustrating though.
Okay, I'm Sandra Dorst, and I have antisynthetase syndrome with JO1, with dermatomyositis and interstitial lung disease. This is my first conference. Unfortunately, I was diagnosed several months after the conference in Reno, which was only 30 minutes away from me. So I had to catch up here in Southern California instead.
And what have you thought of the conference?
I thought the conference was really great. I was excited to see that there were several breakout antisynthetase syndrome groups and an opportunity to speak directly to a physician about our specific questions that are specific to antisynthetase syndrome.
Have you picked up new information?
I feel that I've picked up some new information and also just had information that I believed sort of validated by professionals, which was encouraging. I've been part of a Facebook antisynthetase syndrome support group, which I've got to meet many of the members that I've known for years, so that was an exciting part of coming to this conference. Also part of the myositis group and the interstitial lung disease group, but the antisynthetase syndrome Facebook group is my family for sure.
Hello, my name is Anastasia Victorson, and I came here all the way from Stockholm, Sweden. I'm very happy to be here.
Is this your first time coming to the myositis?
To this conference, yes. To the TMA conference the first time.
What's it been like?
It's been fantastic. Very informative. I've met my friends, my Facebook friends, and I hope I'll be able to come again. I have polymyositis, but I also have a syndrome that's called the Antisynthetase syndrome. I have antibodies, a lot of them, but anti-JO1 is the most common one. And I also have ILD, quite serious. But getting medication, feeling quite okay. The doctor saved my life. Yeah. Very good information. And it's also nice to see the persons. I read a lot. It's also nice to see them in real life, to be able to interact with the doctors. Yes. I'm just happy to be here, having met you too. Take care. And everybody else that hasn't been here, hasn't gotten a chance, please try, because this was really worth it. It's beyond my expectations, really. Thank you.